All right, guys, today we're going to talk about OBGYN emergencies and neonatal delivery. Um, it's a topic because this is not something that we routinely do. However, it is something that we are equipped to do and could have the potential to do. So it's a good topic to just review. And here we go. We'll get after it. So we're going to talk about our different stages of labor. We're going to talk about their trimesters and physiological changes to the mom. We'll talk about our neonatal resuscitation guidelines, what we're aiming to do. We're going to talk about abruptio and placenta previa and define what those terms are. We're going to talk about breech presentations and treatment considerations. And then at the end of this, we'll kind of walk through performing a delivery on a simulated patient, what we want to see have done. So talking about birth statistics themselves, it's hard to tabulate because there's different standards state by state. We do know that every state has to report deaths as well as births, but how that's reported and why is different. And the reason for that is like, obviously, if we go to a hospital and we have a kid, well, that gets tracked. But there's plenty of people out there that kind of live off the grid. There's plenty of people that do home births. So while all that should be going to the vital health and statistics of the county, there are gaps in that within the United States. But as best as we can figure out, there were 3.6 million births in 2024. That's a slight uptick. And what we also see is that preterm births have been rising for about 5 consecutive years. That's some old data now, but it's about 10%, just over 10% of your births are preterm. So boom, you're pregnant, right? So if you see 2 blue lines on a pregnancy test, it is 100%. It's a no doubter, right? So if you have two blue or 2 pink lines on a pregnancy test, you are in fact pregnant. You don't have to go to the hospital to figure out if you're pregnant because that thing is accurate. In fact, the hospital is just going to give you the same thing. So what happens during pregnancy is we determine that mom is pregnant, and now her pregnancy gets divided up into 3 different trimesters. Each one's 13 weeks. So we say 40 weeks gestation is full term. The reality is 39 weeks is just as full term. And it's really important for us to know what week the patient is in, not necessarily month. So if mom says, I'm 4 months pregnant, okay, well, is that 16 weeks or 12 weeks? If I'm 6 months pregnant, are you 24 weeks, 22 weeks? Like, what does that look like? And that's because there's huge physiological changes that are going on with baby as well as mom week to week. Anything less than 23 weeks is considered non-viable. That doesn't mean that we're not going to transport, not going to try. Just understand that because the baby's lungs are massively underdeveloped, there are a few miracle cases out there of like a 20-week-old infant surviving, but that takes a lot of resources at the hospital to be able to do. We can try and do everything that we can. Should we have a preterm delivery before 23 weeks? It's just not very likely. Those are truly miracle cases. That being said, if we had a preterm delivery at 16 weeks, that's pretty much a non-viable option. And then our care is going to be directed towards supporting mom. So during the first trimester, mom realizes she's pregnant and mom's going to go to a checkup, and that's kind of it as far as the medical side goes. Some patients may still have vaginal bleeding, up to 40% of their patients, and just because they have that does not mean that anything is necessarily in jeopardy. Obviously, we would transport, still get mom checked out, but just because they have vaginal bleeding does not mean necessarily that there's something wrong. A lot of women still have spotting during their first trimester. The biggest things that they're going to complain of is fatigue, nauseous, dizziness, and syncope are some of our common call types. So I bring that up because if we're going on a sick person and we get there and it's a female of childbearing age, and childbearing age can be even into the low teens, understand that those might be symptoms of pregnancy. So when we're talking about the first trimester and we're going on these kinds of calls, pregnancy should kind of be maybe possibly in our mind, right? Are we going to question a 14 or 15-year-old girl they're on the side of the road in front of her parents or her friends, no. We should probably do that in private, make her feel a little more comfortable if she's going to be forthcoming for that information. That being said, that these are some common call types that we may see that lead towards a pregnancy diagnosis. If they have abdominal pain, specifically unilateral abdominal pain, so one-sided, that can be an ectopic pregnancy. We'll talk a little bit more about that in a second. It could also be a kidney stone. It could also be an ovarian cyst. So there's a lot of things that it could be, but ectopic pregnancy in the first trimester needs to be one of those things in our Rolodex, if you will. So baby's going to start growing as well. So baby's growing pretty rapidly. During the first trimester, they're going from just a few cells that are dividing pretty rapidly all the way up to actually forming a fetus. So you can see they're in the third and fourth stages there in the 12 to 15 to 20 week mark. So again, the biggest thing that we're going to be concerned about is that ectopic pregnancy. So if they have one-sided lower abdominal pain, then we really got to consider an ectopic pregnancy. If the patient's adamant, no, I'm not pregnant, there's no way I could be pregnant, then we want to ask certain questions like, when was your last menstrual cycle? If they don't know, then again, a heightened suspicion that this could be an ectopic pregnancy. And the reason it's so important is because if the fallopian tube that the baby is growing inside of, so just as a refresher that pregnancy is happening, that fetus is growing, but it's outside the uterus. Unfortunately, it's non-viable, but it's growing inside the fallopian tube. So as that fallopian tube stretches, it can burst, and that's going to lead to septicemia. That can lead to some internal hemorrhage, and can lead to signs of shock and even death. So that's why it has to be a big thing that we need to be concerned about. Also in the first trimester, a spontaneous abortion or a miscarriage. So for whatever reason, during the baby's growing, baby has messenger RNA that is telling the baby what to grow. So we're going to grow arms today, and then we're going to grow kidneys, and we're going to grow legs, and we're going to grow eyes, and all these things. For whatever reason, during that messenger RNA sequence, it sends a stop code. So for whatever reason, something's gone wrong, and the DNA sequence gets messed up, and your body issues a stop code, and baby stops developing, and then baby is expelled. That can happen at any time during the pregnancy, but it has a higher propensity to happen during the first trimester. Again, if there is a spontaneous abortion or a miscarriage, then the biggest concern is going to be back to mom, because she's going to have vaginal hemorrhage, possibly internal hemorrhage, and we're going to be dealing with potential signs of shock. Then, not a huge concern for us, but hyperemesis and dehydration. So as mom is having morning sickness or evening sickness, or whenever her sickness hits, if she can't keep food down, then we're possibly dealing with some hypoglycemia. We might be dealing with some dehydration. So we might be having to try to deal with her excessive vomiting or excessive dehydration as a cause of that. So those are all different things we might be faced with, or things that we have to worry about in the first trimester of pregnancy. So after 13 weeks, she goes into the second trimester. Now we're pretty obvious that we have a pregnant mom. So she starts to show a little bit more. The uterus starts to distend more. She starts to actually have kind of a showing of her belly. And that's the biggest signs that we see where mom is. And a lot of patients at this point, that's where the hyperemesis and the morning sickness kind of stops. And mom gets like really happy, right? So this is where we start getting like baby showers and start to plan stuff. And it's just a really fun time for mom. As physiological changes start to happen to her towards the later end of the second trimester, she might start having some hypertension. But overall, the second trimester is just she's growing, baby's growing, and we're encouraging mom to keep having a great time with her pregnancy. Hopefully mom has prenatal care. So by this point, she's seen her OBGYN. She might be even having a birthing plan. She's gone to the ultrasound. So there's a lot of stuff happening with mom that doesn't really deal with us as far as EMS goes here. So again, at 5 weeks, can't even tell. 13 weeks, there's a little bit of a tell if you were even looking. But by 25 weeks, just a little bit short time later, mom is very clearly pregnant as that uterus starts to extend and her belly starts to kind of protrude out. So some of the changes that are occurring is, again, babies growing, they need blood and oxygen, right? So mom is eating for two. Mom is now supporting this baby inside of her. So to do that, mom has to compensate. So mom has to make more blood and circulate more blood. So her respirations are going to increase just a little bit to incorporate supporting two lives, not only her vital organs, but also baby's vital organs. Heart rate goes up a little bit as well. So it's normal to have a little bit of a higher heart rate. So if mom's heart rate was 60 to 70, it's okay that now it's 70 to 80, or even maybe even 80 to 90. We should not see supraventricular tachycardia. We shouldn't see shocky looking tachycardias like 120, 130 heart rates. That should not be a normal thing. Blood pressure goes up a little bit as more blood circulates. That's a normal finding as well, but it shouldn't go crazy high. So we shouldn't see super hypertensive patients here, because if you start seeing super hypertensive patients above 160 systolic, then we're going to get into the pre-eclampsia stages. Babies also need nutrition, so mom's going to increase her feeding. So this is where she starts getting some cravings. That depending on what those cravings are and just kind of what's going on in mom's body, that can lead to gestational diabetes. She's going to have some increased weight gain, and she can be easily fatigued with activity, especially towards the later end of that second trimester and into the third trimester. So if you can imagine, she's carrying this baby inside of her. She's holding a 10-pound or 10 pounds of baby with fluid and the uterus and everything like that inside of her, and we're asking her to walk up a hill. That's going to get old pretty fast. So she's carrying this kid around 24 hours a day for months. She's going to get easily fatigued. So that's a normal finding as well. And then after her 26 weeks, she's into the third trimester. So now mom's uterus is very much more pronounced. As we start getting to the 36, 37, 38 week mark, she starts having some walking issues because she can be prone to falls. And that's, again, because she's kind of top heavy. She's belly forward, so the child is kind of the first thing that's arriving into the room. Mom's gait is kind of shuffling now because she's having to walk with this bowling ball strapped to her. And because of that, she's a little top heavy. So as mom is walking up and down stairs with laundry baskets, or mom is carrying things from the car to the house or from the house to the car, she's more easy to trip. And because of that, they're more prone to falls. Also, because the baby belly is kind of the first thing that's most pronounced on mom, that's going to cause some issues during crashes. So mom's driving to prenatal care, mom's driving to work, whatever, and she gets in a car crash. Well, that seatbelt is right across that belly, and then the belly's sitting really close to the steering wheel. So that's where we're going to see issues during a motor vehicle crash, is during that third trimester and late in the third trimester. So again, belly's more pronounced there, and you see towards her the left side of the screen, or the right side of her, that's baby's foot. So baby's kicking and moving and kicking her ribs and kicking her organs and everything like that. You can see towards the end of a third trimester, baby's foot kicking out. So that's something that can happen a lot. Also, mom's tired, right? So babies, because of just their activity, right? They're awake inside the womb. Baby's happy. Baby's comfortable because there's 98.6 in there. Baby's cushioned. Baby can hear the outside, but baby's happy. And because baby's happy, mom goes to bed. Mom's relaxed, or trying to get comfortable as best as she can, and baby decides now's the time we want to play. So baby's moving and kicking her ribs while she's trying to sleep. During the day, she's up working, doing all the stuff, getting ready for baby, and baby's not doing anything because baby's sleeping. So there's also those factors that play into mom late in the third trimester. So specifically talking about trauma in pregnancy, we want to consider trauma to the fetus if trauma occurs to mom's abdomen. So if mom took a blow to the abdomen, then baby took a blow to the abdomen. So we want to be concerned about that. Our common causes would be car crashes, falls, and then sadly abuse. We want to assess the area that we're in for signs of abuse, right? So if we're seeing those spidey senses or the hair on our neck sticking up because something just doesn't seem right in our assessment, then we want to be concerned for signs of abuse. Things we want to consider, as well as bruises in different stages of healing, alcohol and drug dependency, obviously those environmental clues that kind of might clue us in more to abuse. And then obviously with dispatch, if we've had multiple runs to the same area for similar things, that would be a sign as well. The biggest things that we're worried about with this is if there's trauma to baby, then that's also trauma to the uterus. Is that going to cause internal hemorrhage? Is that going to cause abruptio placenta, perhaps? So some complications that can occur is gestational diabetes. We talked about that in the second and third trimester, and that's just uncontrolled glucose levels that occur in the second and third trimester. You don't see gestational diabetes in the first trimester. So if you have a female who's 6 weeks pregnant and she's hypoglycemic, she's probably diabetic naturally. So, or she's just hypoglycemic. She probably lives with diabetes. Gestational diabetes comes on in the second and third trimester. Same thing with preeclampsia. If we see someone who's hypertensive and they're 8 weeks pregnant, they have categorically just have hypertension. Hypertension related to pregnancy occurs again in the second and third trimester. And then eclampsia, that is seizures due to preeclampsia. So a patient who is 10 weeks pregnant who is seizing, they have epilepsy. A patient who is 37 weeks pregnant and seizing, that is likely eclampsia. And the eclamptic seizure is due to hypertension or preeclampsia. Also to note is that eclampsia can occur 4 to 6 weeks postpartum. So if we have a 3-week-old and mom is seizing, consider eclampsia. And I bring that up because our treatment is completely different. When we're treating epileptic seizures and those tonic-clonic seizures, we want to be on Versed, right? So we want benzodiazepines to break the seizure. We can do the same thing with the eclamptic seizure to try, but the drug of choice here is going to be magnesium sulfate. So we want to be giving magnesium to break the seizure in an eclamptic setting versus Versed. So as we're doing our assessment, so we're on scene of a pregnant female, we want to look at our normal scene survey observations. So again, are we looking for signs of abuse? We're looking at their mental status, airway, breathing, circulation. Obviously, treat any threats to those immediately. And then we go into our focused assessment when we're able to. So our focused assessment is going to be more OB-centric. So I want to know gestation. Again, how many weeks are you? Gravidity, parity, complications, and abortions. I want to know those extra things. And we want to know, are they receiving prenatal care? If they are receiving prenatal care, find out where. Is it Mercy Fairfield? Is it Christ? Where are they receiving the care at? Because mom often has a care plan with a physician at those hospitals. And so ideally, we want to go to that hospital where she's expected to deliver. The reason for that is the doc's on call there. She's got a whole care plan set up. That's where we want to go. However, if there are threats to life, i.e., we have an unstable airway, she's bleeding because this is trauma, then obviously transport to a trauma center, ideally Westchester Hospital, and then they can also handle the OB component. If it's just a standard delivery, mom's water broke, we're going to the hospital, then we usually have time to transport to the hospital she wants to go to. A caveat to that is high-risk pregnancy. So Good Sam Hospital, downtown Cincinnati, is a high-risk pregnancy center. So is UC downtown, or UCMC. So if you hear those hospitals as, I need to deliver at these hospitals, then the question then becomes from us as care providers as to why, and find out what that high-risk issue is. Is it because they're eclamptic? Is it because we're dealing with multiple births? What is the thing that's making this a high-risk pregnancy? And we just want to know that so that we can anticipate if we go into a field delivery, what complications could be arising. So again, the gestation, how many weeks are you? Gravidity, how many times have you been pregnant? And that includes if you've been pregnant and had a miscarriage. Parity, how many children do you have? Care and lifestyle, are you receiving prenatal care? And then transport, what hospital are you delivering at? And then we want to try to go to that hospital. So some common complications that we might see that definitely for high-risk pregnancy stuff, but also just complications of pregnancy in general. multiple births. So not only like, hey, how many weeks are you? But it's a good thing to know if we're going to be doing a field delivery, how many kids are in you? So are we having one child, twins, triplets, quadruplets? What do we got to deal with here? Because that's going to quickly tax resources. We only have X number of OB kits on the medic unit. And I'm here to tell you that if we're just having one delivery, open both OB kits. If we're going to have multiple births, get more ambulances there, because if we're trying to transport 3 kids and mom, we're going to have to figure that out, right? We can't just put 3 babies on the cot and have mom hold all 3 like a litter of kittens. We're going to have to do multiple transports using multiple squads. Breech presentation is an issue. Placenta previa is also an issue. So placenta previa is something that mom hopefully knows about because she's been getting good prenatal care. And basically what happens in placenta previa is it prevents a natural birth. That's because the uterine wall and the uterus itself forms over the cervix. So the baby cannot pass through the birth canal because it's blocked up by a giant placenta. So because of that, baby has to come out via C-section. Baby will push on that placenta. Baby will try to go through the placenta. Baby cannot go through the placenta. Every time baby's head contacts the placenta, then mom's going to have lower abdominal pain and maybe even some spotting blood. But baby cannot go through that thing. So it's going to be a C-section. If we see a woman in labor with spotting blood and lower abdominal cramping that's a little bit different, that's like coming and going, then we want to consider placenta previa. Obviously, past history of miscarriages, gestational diabetes, and then any history of preeclampsia or eclampsia is going to create complications for high risk. So boom, we're having a baby, right? First thing that's going to happen is this. Mom's going to freak out and say, oh my God, my water just broke, right? So you can have Braxton Hicks contractions. And Braxton Hicks contractions are just that. They're fake contractions. They're contractions that are just happening to get mom ready to have the baby. Mom's mucus plug is going to drop out at some point. That does not mean that we're going to start having a baby right now. It's when her bag of waters breaks, right? So the mucus plug drops out, and then within a few days, then her bag of waters is going to break, and it's time to go to the hospital. So just like in pregnancy and just obstetrics as the baby's developing, we have 3 trimesters. We have 3 different stages of labor. So the first stage is by far the longest. And the more children that mom has, the stages of the first stage of labor becomes much shorter. So if this is mom's first pregnancy, she's never had children before, she's not high risk complicated, we have time. We've got hours and hours of time. We can transport this mom to the hospital and then go available. And sometimes we think we show back up 2 days later and baby still isn't here because it was all Braxton Hicks. So the first stage takes forever, anywhere from 16 to 20 hours. If we go past 24 hours of labor, typically that's when the hospital will do a C-section. And the reason for that is mom's mucus plug is gone, mom's bag of waters is broke, so there's basically an open route now for possible infection, and we got to get baby out. Baby's been trying to come out for 24 hours. Mom's tired, baby's tired, time to get baby out. First stage of labor transitions to crowning, and that starts the second stage, right? But labor concludes with delivery and the expulsion of the placenta in totality. So there's 3 stages of labor. It starts with, hey, my water just broke and I'm having contractions, and goes all the way through until the placenta is delivered. So again, the mucus plug drops out, cervix begins to efface and starts to dilate, right? So once the bag of waters ruptures, we're on the clock. We again talked about false contractions and false labor known as Braxton Hicks. They're real contractions, right? So there's no way to tell in the field if these are real or fake. The only way we know if it's real or not is if these contractions are getting closer and closer apart, and then we look down and we see a baby. So that's the only way to tell them apart. They look real. We're going to do everything as if it's real, and then we go back 3 days later and we're doing the same exact thing because baby didn't show up. It can occur several weeks prior to the due date. They're very, very, very common. Again, we treat it as an actual labor and then transport. So we want to do a vaginal check, right? So mom's bag of waters is broke. We want to get her to what's going on, and then we need to check. Ideally, we need to check as soon as possible. So we want to examine the area visually for signs of meconium staining. If we see meconium, that indicates fetal distress. And what's happened is baby's basically had a bowel movement inside of mom. And now inside the womb, inside the birth canal, there's poo. And that poo is getting in baby's mouth, getting down baby's airway, and basically causing some issues for baby. So we're going to also check for crowning. So this is an example of meconium staining. So baby has basically pooed. So now we're checking for crowning, and we're going to see a head, right? So if we look down and we see a giant head of hair coming out of mom, it's on. So whatever plan you had as far as transporting and we're going to get to the hospital just went out the window. If we don't see crowning right now, then we probably have a little bit of time. The cervix itself has to dilate to 10 centimeters. So again, that's why it can take 16 to 20 hours or longer to get it to dilate to that size. We want to time our contractions for frequency and duration. So how often are her contractions occurring? And how long does each contraction happen for? And the reason for that is because as the contractions happen more and more frequently and they take longer and longer and longer, means we're getting real close to having a baby. If contractions are 6, 7, 8 minutes apart, lasting 10 seconds each, we have time. If contractions are 2 minutes apart, 1 minute apart, lasting 30 seconds each, we do not have time. It's time to prep for field delivery, and we're going to get ready to do this thing. So just like there's complications within obstetrics, there's complications with birth. So these are some of the things we might see is a nuchal cord. So baby's coming out. Once the head is delivered, we want to check for a nuchal cord. So I want to run my fingers around the neck really fast. I want to make sure that there is no cord on the baby, because the more the baby comes out, the more it stretches the umbilical cord, and you're going to end up strangling baby. So I want to feel for a nuchal cord all the way around the neck. If there is one, with 2 fingers, I try to slip it over the head of the baby. If that does not work, clamp, cut. You have to do that clamp and cut right now, because baby cannot be born with a nuchal cord. You're basically are strangling the baby on its own umbilical cord. It is very common. Nuchal cords happen all the time, every single day in births. So it's not a freak thing to see. It's actually a fairly common thing to see. We might have a prolapse cord. So if we have a prolapse cord, this is now a rapid transport, because baby's probably going to have to come out C-section. For the same reasons that the baby can't go past a nuchal cord, they'll strangle themselves, is the same reason they can't go up past a prolapse cord. They're going to get wrapped up in it, tangled in it, and suffocate. So with a prolapse cord, the cord's hanging out, there is no baby. I want to keep the cord moist. I want to transport rapidly to the closest OB hospital possible. You might have a frank breech where the buttocks is protruding from mom. A frank breech is another C-section, because baby cannot be born that way without causing multiple fractures of baby. So that's another rapid transport. We could have a footling breech where the feet are sticking out. This is one where you can deliver. It's not ideal. However, depending on what's going on, you might have to deliver that way. Obviously, try to transport, but if the feet are sticking out and baby's falling out backwards, we can't really stop that process. The issue you're going to have is the shoulders. Be prepared for, as soon as baby's chest is delivered before the head, baby wants to start taking a breath, and we got to get baby's head out of there. Also with that issue is, again, the incidence of fractures and trauma to baby goes way up with footling breech. Then you have limb presentation where like the arm is sticking out or a hand is sticking out. Again, that is another emergency C-section rapid transport. With any of these, if you're transporting mom, because we can't do a field delivery because baby's coming out a different way, we want to transport mom head down. So get her on high flow oxygen, get her head down and her hips elevated. That's going to help hopefully allow gravity to hold baby inside mom. That's the only thing we can do besides driving fast to get her to the hospital to get this handled. She's going to buy if you have any of these going on in a field delivery, she's going to buy a C-section in the emergency room. Also, if we're just transporting mom, you might have supine hypotensive syndrome. So what supine hypotensive syndrome is for whatever reason we got mom laying flat. Maybe we're concerned about C-spine or maybe some type of immobilization, and the uterus itself ends up collapsing the vena cava, so the return blood supply to the heart. We need to be able to get the uterus off of her. Now, traditional education would say tilt the backboard. Well, since we hardly ever use backboards, the thing I would say is tilt the uterus. So you might just have someone to manually push the uterus off to one side, preferably the left side, and that way that'll increase blood, to the right side, which will increase blood flow to the vena cava and restores circulation so that mom wakes back up. If you lay mom flat and she passes out, that is a supine hypotensive syndrome patient. So again, prolapse cord, the cord's presenting out of the vaginal opening. We want to keep it moist and warm, so put towels on it and then soak those towels in saline, keep them warm, wrap in dressings, elevate mom's hips, head down, rapid notification and rapid transport to the ER. We talked about the frank breech. Again, if there's high morbidity and mortality of the infant, multiple fractures are likely. This is a rapid notification to the ER for a C-section as well. Footling breech can still be field delivered, but again, aggressive airway management and a difficult delivery is going to follow. So if the feet are protruding, this is still a rapid transport. Get extra people in the back with you. We can't necessarily slow this down, but if mom decides to deliver this way, which I've had one delivery like this, mom might expel baby out and they come out backwards. Limb presentation, rapid transport to the ER for a C-section as well. And then again, the supine hypotensive syndrome patient, push the uterus off, reposition them so that blood flow is restored to mom. So typically what happens in a field delivery is someone says, oh my God, I can see the head. Well, you're supposed to see the head. We have a delivery. So, and then boom, we're about to deliver a baby because of it. So what we want to do is get the back of the medic set up, but we might not be able to get to the medic unit. We might just be getting anywhere we can set up. So that might be the living room, that might be the kitchen, that might be the bedroom. We don't get to pick our workspace. Ideally, it's the back of an ambulance where we have all of our toys, but right now, it might just be wherever we find ourselves. It might be in a car on the side of the highway. So scene safety matters. Depending on where we're at, get additional resources there. Open up both obstetrics kits. And the reason for that is because this OB kit is designed with minimal equipment, and you're going to be freaking out, and your hands are going to be dirty and slimy and all sorts of stuff, and you're going to need a thing. You're going to need a clamp just to cut the cord. And when you open this, all the clamps go everywhere, so it's better if you just open both OB kits. You can never have enough towels. Maintain privacy as best as possible, especially if we're in a public setting. You might just need additional resources just to do that, or hold a blanket while we do this. But people have been delivering babies for thousands of years before EMS, and we just have to make this work. So ensure mom has good airway and ventilatory rate, of course. Give her some oxygen. There's no known damage to babies by supplying mom with high flow oxygen. Now, does that mean that we need to do a non-rebreather mask? No. Nasal cannula with some capnography attached to it at 4 liters a minute will work just fine. The reason is because we want to maximize oxygen going to baby, going through the placenta, through the blood-brain barrier, just to make sure that everything is going to be good. Coach mom's breathing, help her to take nice big deep breaths, and she's going to want to push. With circulation, again, make sure there's no bleeding that we need to take care of first. Get IV access if you're able. We don't necessarily need to hook her up to the cardiac monitor. That's just going to create more of a mess and more stuff that's going to be in our way, unless the patient's in shock. So then we're going to see crowning. So what we want to do is place the palm of our hand on top of the baby's head. What that's going to do is just a little bit of gentle pressure, right? We don't want to push, but we just want a little bit of pressure to reduce the chance of a precipitous delivery. Basically the baby shooting out of mom uncontrolled. We're going to deliver the head. And then as soon as that head's delivered, we're going to check for a nuchal cord. Also, as the head comes out, most times the head is going to be facing down. So baby's face is going to be kind of faced towards mom's butt. Baby's head's going to rotate one way or the other. Allow the head to naturally rotate. That's a normal thing that happens kind of as a corkscrew through the birth canal. Again, this is an example of a nuchal cord. If we cannot get this cord off of baby right now, we have to clamp, and cut. Where those clamps get placed and how you cut does not matter in this case. It is going to be fast and aggressive. It's not a should we debate. It is we need to do this right now. Option 1, slip it over the baby's head. 9 times out of 10 that works. If that doesn't work because baby's too far past it, then cut the cord. So we check for the nuchal cord, we clamp it, we cut it if we're unable to remove it, we leave it alone if it's not involved. So if there's no cord there, don't have to worry about it. Next thing that's going to happen is the shoulders. So what we're going to do is take the baby's shoulders and rock the baby's shoulders down towards the butt of mom, towards her soft tissues. And that was the last chance you had to keep baby in there. So what's going to happen is as you rotate the shoulders down, the top shoulder of the baby is going to clear mom's pelvis. As you pull the baby back up to clear the bottom shoulder, that's when you're going to have a kid. And it is that fast. As soon as that second shoulder clears, boom, you have a kid. So head's going to rotate one way or the other towards mom. Check for a cord. If none, press down to get the top shoulder to clear. Take a big deep breath. Make sure you're ready. Clear the bottom shoulder and then catch the child. Boom, there's a baby. And now you're going to freak out, right? And like, what do I do, right? We have a kid here. That's new. Well, we're going to suction the mouth, then the nose, right? So suction the mouth and the nose using the bulb syringe that's in the OB kit. If we lost it, that's why you open 2 OB kits. If we lost both of them, there's one in the PD kit. So in the PD pack from Children's, there's a bulb syringe. And then we're going to cut the cord, right? So we want to be about 4 inches away from baby for our first clamp, and then 2 inches beyond that. And then we can use the scalpel or the scissors to cut. As a pro tip here, let dad cut the cord, right? So dad has been involved in this process in his head the entire time. Mom has done all the work, but dad feels like he's been a real big helper. He's been holding her hand. He's been running back and forth to get towels and whatever, and he kind of feels helpless. This is that moment where dad's really excited, and he's going to feel like the biggest hero of this entire thing. So let him cut the cord. And then we need to dry, warm, stimulate the baby. So wrap the baby in blankets, put the hat on the baby that comes out of the OB kit, towel them off, flick their feet, rub their back, and what's going to happen is we're going to pinken up this baby. And what's going to happen is this baby's going to start crying and start making all sorts of noise, and that's great. That's what we want to hear. We want to do an APGAR score. So this APGAR score takes place at 1 minute and 5 minutes postpartum. As we do the APGAR score, the reason is because we need a way to be able to assess this kid is 1 minute old. This kid's birthday was 60 seconds ago. So what are their vitals like? So we need an objective way of doing that, and that's through the APGAR score. It also guides what we do next. So the APGAR scoring system looks at 5 factors: activity, pulse, grimace, appearance, and respirations. It's scored 0 to 2 in each category. So if this baby is crying aggressively, like a nice loud cry, that would be its respirations. They get 2 points. If they're moving all over the place, that's their activity, 2 points. If they have a good pulse rate, so it's over 100, we're good. If it's less than 100, they get 1 point. If they're completely pink all over, they get 2 points. Typically at the 1 minute mark, it's not uncommon for their body to be pink and their extremities to be blue. They get 1 point for that. We kind of put these into 3 broad categories. So if they're excellent condition, it's APGAR 7 to 10. If they're moderately depressed, 4 to 6, and severely depressed, 0 to 3. If we have a good APGAR, that's 7 to 10 range, and we want a kid to be about 7. 7's kind of borderline. We'd love a kid to be 8, 9, or 10. If they're 8, 9, or 10, baby goes to mom. We start what's called kangaroo care. We want baby to rest on mom's bare chest. So we want her to expose her breast, to start nursing, to go skin-to-skin contact, right? We don't want baby to be on like a blanket or on a sweatshirt. We want skin-to-skin contact. Mom is 98.6, baby is getting cold fast. So just like in hypothermia, right, where two people like go skin-to-skin contact, that's exactly what we're doing here. Baby's wrapped up in a blanket, unwrap the baby, put it on mom's chest, and then wrap both up with a blanket again. So keep baby warm. That's so important for their pulse rate. It's also good to help mom's dopamine, her estrogen, her progesterone, all these hormones that are being released inside mom, which also helps to stop vaginal bleeding. So this is, again, the example of kangaroo care. So mom and baby, skin-to-skin contact, we got our blankets on, and mom now is happy, right? Mom's been dying to see this kid for the last 9 months. Mom feels good. However, what if the baby isn't doing well? Well, if they're not healthy, so if we have that moderately depressed kid, APGAR 4 to 6, then we're going to start BVM ventilations on room air. Do not give them blow-by oxygen. Number one, it doesn't work. And number two, we can cause more harm to the baby. Baby has never breathed our atmosphere before. Baby was plugged in via an umbilical cord to the placenta. Baby got all of their oxygen through mom. So we don't need to give them 100% O2 because our atmosphere is a 21% O2. It can actually cause some issues down the road. Instead, we're going to give 30 breaths, 1 breath per second. So we are going to rapidly ventilate this kid with a pediatric BVM, an infant-sized BVM out of the PD kit quickly. So we're going to quickly ventilate them, watching for chest rise and fall, 1 breath every second. This does a lot of good for them. So just that room air BVM pinkens them up more times than not. Sometimes kids are just having a weak cry. They just need a little more assistance, and that's all this is doing for them. If there's no response to that and their pulse rate is below 100, right, so we're starting to get into that, starting to Brady down, start CPR. Our CPR is not 15 to 2 like we teach in AHA. It's actually 3 to 1. So 3 compressions to 1 breath. And that goes all the way up to age 28 days. So a neonatal child is actually 3 to 1 chest compressions up to almost 1 month of age. This is the point where, hey, O2 is getting attached now. Now we're into full-blown ACLS guidelines here. This is a super rare thing to have happen. Unfortunately, it does happen every single year. However, most kids come out, have a good strong cry, a good APGAR score, and do very, very well. Unfortunately, some kids are going to be respiratorily distressed. They start to kind of crash on us, and that's where we start getting into CPR. We're going to go into PALS, so we might do we're going to initiate vascular access, likely through an IO. We're going to start our medications, right? So our epi is 0.04 milligrams, or 0.4 cc's or 0.2 cc's for a premature infant. If we're going to go an ETT route because we can't get IO access established, we're going to double those to 0.8 and 0.4 respectively. So that's our dosing straight out of our protocol. And at the same time that's going to be going on, we need to care for mom. So even if baby's doing well, all of our focus is going to be on the baby. Don't forget, we just went from 1 patient to 2. Mom still matters. So we want to make sure that mom's doing well. We want to make sure that she doesn't have any uncontrolled bleeding. We do not need to pack any wounds, so don't pack the vagina with quick clot. That's not going to do anything. If she is having uncontrolled hemorrhage, IV boluses, oxygen therapy, and then start your 250 to 500 cc titrated boluses to maintain her BP. Things you can also do to kind of help with the uncontrolled hemorrhage is fundal massage. So start taking her belly, her soft belly now that baby's out of there, and start just kind of really aggressively massaging it. What that does is it releases more hormones to kind of do some vasoconstriction inside. And then get ready because we're not done yet. So the 3rd stage of labor is the placenta delivery. We don't want to pull on the umbilical cord. So baby's now been clamped and cut. Baby's got kangaroo care. Mom's doing very well. Here shortly in the next 15 to 30 to 45 minutes or so, mom's going to deliver the placenta. She's going to go through labor her abdomen is going to tighten up, she's going to have contractions, and she's going to expel a placenta. That is normal. We want to collect it and give it to the labor and delivery staff so that they can run tests to make sure that everything is good. Culturally, they might want to do stem cells or to harvest things off of the placenta. So that's why we want to collect this. All we do is collect it in a specimen bag. So these are our associated protocols. So P600 is our newborn resuscitation. Our 0800 is the imminent delivery, and 0801 is pregnancy complications. That's where you'll find stuff like magnesium sulfate for eclamptic seizures. With that, that wraps it up. In summary, pregnancy is not something to be scared of. Most moms are excited. Most moms have good prenatal care. However, as we have a lot of visitors that come through our town, people might be traveling from out of town for soccer or baseball or what have you through because we travel along I-75. It's not out of the realm of possibility that we might be called to do a field delivery. We've already done several of them on I-75 over the years. A lot of us have had OBGYN incidents, especially with some of our immigrant population and some of our unnatural or naturalized citizens. Sometimes we might be called to assist with the home birth. So there's a lot of stuff that goes on with it. The biggest thing is fall back on your training. We want to do a good OBGYN assessment. We want to know how many weeks they are, if there's any complications, are they high risk? And if we're involved in a field delivery, 2 OB kits open, make sure we're doing a good assessment on mom, oxygen with a Catno line, and then get ready to rock. That's it. If anyone has any questions, feel free to get with me. Thanks for tuning in.